Good morning, everyone, and welcome to our Medicare Fundamentals webinar here today. I am Chelsea Smith. I am a Learning and Development Specialist here at Action Benefits to help you get the knowledge you need to be an effective insurance agent. Joining me today to help me out is my friend Jessica. She has been here for 10 years now, helping you guys with your group and Medicare, individual and Medicare needs. Jessica, why don't you go ahead and say hello before we get started?
Hey everyone, just want to say hi. Please reach out if you have any questions after this training, okay? See you soon.
All right, thank you very much for that. So let's go ahead and jump right into our Medicare fundamentals. So by the time you finish this webinar today, you should be able to define the parts of Original Medicare, identify ways to supplement Original Medicare, and describe pathways for clients to enroll in Medicare. So 3 pretty basic ideas of Medicare. I do appreciate your patience with me in this quick portion of our show while I read you a very quick disclaimer. So now I can get a taste of what you guys have to do every day when you're on the phone with your clients. So there is a disclaimer that comes with this session, and it should only, hopefully, be for this session only. So as of today, the 10th of October, CMS has not released any of the official costs for 2024 quite yet. So therefore, any information that is indicated for 2024 has been taken from the estimates located in the 2023 Medicare Board of Trustees report. There are some figures that were not estimated at all, and those are 2023. I left those as 2023 figures, and those are accurate. Those obviously have been around for about a year now, so those are not estimates. Those are accurate to the what they already are. So like I said, usually this information is out by now, but they're taking their time to put it out. So these data points, if they are 2024 data points, they are estimated. So keep that in mind as we are going through this webinar. I will try my best to remind you as we see those estimates, when they are estimates and when they are accurate. So, yep, awesome, Jessica, thank you. I had Jessica throw that report in there for you if you want to take a look. It's real long, so prepare. It's not light reading, so prepare, but it is really neat, really nifty. It sometimes like puts out predictions as far as like the 2040s, and I think that's so interesting. Anyway, so just so we know, some of that is a estimate. So let's jump on into defining what Medicare is. So the senior healthcare market is pretty complex, as we know, and we're here to help you navigate it and find the solutions that best fit the needs that your clients might have. So for those of you who may be brand new to this market, here's a quick rundown of why it can be so complex and why seniors need help from agents and support staff like you to select the most appropriate option. We take a deeper dive on these topics in other webinars and courses within knowledge base and insurability and what have you. I'm sure many of you are familiar, but if you're not familiar, I totally encourage you to go participate in those courses and webinars. I'm a little biased since I'm, partnered in making them, but they are very helpful if you are looking for a quick refresher and a webinar is not coming up in the future, so on and so forth. But for now, we're just going to do more of an overhead level. And I'm going to give you some brief explanations on some of these portions of Medicare. So way back on July 30th, 1965, President Lyndon B. Johnson signed the Medicare and Medicaid Act into law. And that law established Medicare Part A to cover inpatient services. So inpatient services would be things like hospital stays and skilled nursing facilities. And Part B to cover outpatient services. So think things like doctor visits, specialist visits, and preventative care. Medicare is available to those who are 65 years and older, those with certain disabilities, and those who have end-stage renal disease or ESRD. But the people wanted more. So Congress updated that legislation over a few years to allow supplemental policies to be provided by private carriers for purchase by those consumers. These policies cover additional items like travel emergencies, and provide financial support to cover the deductibles and coinsurance, depending on their issue date or what kind of coverage they have. These plans eventually became standardized in the Consolidated Omnibus Reconciliation Act of 1990, which some of you might recognize in its short name, COBRA, that went into effect in 1992, but it's a different COBRA than the COBRA that extends coverage when you have certain qualifying life events. Different COBRA, bunch of different COBRAs. But we're still not done. You haven't heard anything yet about drug coverage. So Congress addressed this with the Medicare Modernization Act of 2003, allowing private carriers to begin issuing Part D policies in 2006. I always think D for drug. So you'll notice that we skipped over Part C, and we'll come back to that right now, because Congress in 1997 passed legislation to allow private carriers to enter the senior market. And at that time, those plans were referred to as Medicare choice plans, because they gave consumers the choice between a public or a private option for their senior health care. Later on, that Medicare Modernization Act that we mentioned earlier allowed private carriers to bundle Part D benefits into their choice plans and rebrand them as Medicare Advantage plans. Today, these plans are combined as Part A, B, and usually, but not always, D, and have other embedded benefits like routine dental, vision, and hearing benefits. Other benefits could include like gym memberships, chronic condition support, companionship services, food support, travel support, all sorts of different options out there for your seniors. So here we are having 5 distinct programs that seniors could be eligible for once they turn 65, but a variety of legislation and rules govern the ways that these programs can work together. So generally speaking, a beneficiary must always enroll in Parts A and B, original Medicare, as it might be called, or vanilla Medicare, to be eligible for the other programs that are out there. They also will be responsible for Part B's premium every month. And after enrolling in Parts A and B, a beneficiary has the option of enrolling in one or both of a Medicare supplement policy and a Part D prescription drug plan. A beneficiary also has the option of enrolling in Parts A and B alongside a Medicare Part C plan, but it is illegal for a member to enroll in and for agents and carriers to sell supplement or Part D plans to someone who's already enrolled in a Medicare Advantage plan, since Medicare Advantage plans offer the same benefits that a combination of supplement and Part D would. So I know this sounds complicated. There's a lot of different overlaps, but hopefully that explanation can help us understand why seniors might need some help advocating for themselves within this complex marketing system. We have a lot of different ways of covering ourselves and each other using these benefit plans, right? And who is there to help you but your friendly faces at Action Benefits, right? So we're here to help you. So let's talk first about original Medicare, because this is kind of like our like foundation or basis for the rest of the Medicare plans that are out there. So you'll notice at the top right of your screen, there is a sort of pyramid that has A, D, and B in there. That is because, as I just said, those are kind of the foundations for the rest of what Medicare can offer to your clients. So in order to get things like C and D, you must have A and B, right? So let's start with A first while we hit on. So usually you don't pay a monthly premium for Part A if you or your spouse paid Medicare taxes while you were working. This is sometimes called premium-free Part A because, lo and behold, most of us do not end up paying a premium for Part A. The Federal Insurance Contributions Act, or FICA tax, is a U.S. federal payroll tax imposed on both employees and employers to help fund Social Security and Medicare. About 99% of people with Medicare don't pay a Part A premium since they've worked at least 40 quarters of Medicare-covered enrollment. So most of us don't end up paying for Part A, but some of us will end up having to pay because we didn't work for that long or whatever. And if you aren't eligible for premium-free Part A, you may be able to buy Part A if you're 65 or older and you have enrolled in or are going to enroll in Part B and meet the citizenship and residency requirements. In most cases, if you do choose to buy Part A, you must also have Part B and pay the premiums for both of those parts. The amount that the premium will be is going to depend on how long you or your spouse worked in a Medicare-covered employment, right? So you can get partial or full premiums for Part A depending on if you worked a certain a little bit or if you didn't work at all. So Social Security determines if you have to pay a monthly premium for Part A. So in 2023, because they have not made this data yet available for 2024, the Part A premium for a person who has worked less than 30 quarters of Medicare covered employment is $506 a month. Those who have worked between 30 and 39 quarters of coverage may buy Part A at a reduced monthly premium rate, which is $278 for 2023, again, because those numbers have not been made available for 2024. You might also pay a premium for Part A if you are under 65, disabled, and your premium Part A coverage ended because you returned to work. So people who are under 65 and disabled may continue to receive premium-free Part A for 8.5 years after they return to work. So those are kind of niche scenarios, might not happen for everyone, but there are other options to getting Part A outside of working those 40 quarters. So that's Part A in a nutshell. So let's go over some of the coverage that Part A would give you. So Medicare Part A's hospital insurance helps cover medically necessary inpatient services. So inpatient hospital care in Part A would cover things like semi-private rooms, meals, general nursing, hospital services and supplies, as well as care in inpatient rehab facilities and inpatient mental health care in a psychiatric hospital. But that psychiatric hospital care is limited to a 190-day lifetime limit. A little different of a limit than it is for a regular hospital inpatient stay. Everyone who's covered with Part A is covered for inpatient hospital care when all of these things are true. So a doctor makes an official order which says you need, as of 2013, 2 or more midnights of medically necessary care to treat your illness or injury, and the hospital formally admits you. You need the kind of care that can only be given in a hospital. The hospital accepts Medicare. The Utilization Review Committee of the hospital approves your stay while you're in a hospital. The rules are a little different, though, for inpatient skilled nursing facilities, or also known as SNFs, but not custodial or long-term care if you meet those criteria. SNF care and custodial or long-term care are 2 totally different things. Those are not covered by Part A, just the skilled nursing facility. So skilled care involves safe and effective care given by skilled nursing or rehabilitative staff. Skilled nursing and therapy staff includes things like registered nurses, licensed practical and vocational nurses, physical and occupational. Oh no, I do that once a webinar. I'm so sorry. Physical and occupational therapists, speech language pathologists, and audiologists. Coverage requires a minimum of 3-day inpatient hospital stay. So you must be there in the hospital for 3 days and to be able to qualify for that SNF. So other things that might not be covered would be kind of like your TV and your phone, things like toiletries. Those things will not be covered by your Part A. All right, so here is a look at some of the Part A deductibles and coinsurance amounts that are estimated for 2024. So this is up to date as of the estimates, but this might not be the exact numbers later on once we find out what those are. This is just to get an idea of how coverage works with Part A. So if you have Part A and will be spending some time in that hospital, you will have a $1,652 deductible for that first 60 days that you spend in the hospital. So that's $1,652 for 60 days, not per day. That'd be insane. So on the 61st day, if you are still in the hospital, that deductible is reduced to $413 estimated, but you pay that every day until you hit that 90th day. After that, each beneficiary gets a bank of extra days called lifetime reserve days, right? Which have a $826 estimated deductible, there we go, per day associated with them. These days can get applied in any increment that you need them, but you only get 60. If, God forbid, you spend time in the hospital past that 60-day reserve point, you are 100% responsible for all the costs that you accumulate while you're in the hospital. Hopefully none of us make it to that point. However, like I mentioned earlier, you can only spend 190 of those days in a psychiatric hospital. So again, the numbers are a little different if you're going to spend that time in a psychiatric hospital. After a hospital stay, you might find yourself in need of some type of additional care that is outside the scope of a hospital. And for that, you need a skilled nursing facility. Your first 20 days of your benefit period is free. And this time you're working with co-insurances, which means that you'll pay a flat rate of $206.50 per day estimated from day 21 to 100. And after that, you would be responsible for all the costs that you accumulate while you were in that SNF. If you need home health care services, Medicare has got you covered there, so long as you only need intermittent skilled nursing coverage. So again, a little different than your SNF situation. Okay, I know we went through a lot. Okay, so how do benefit periods work? So on the previous slide, we talked about benefit periods a little bit. These describe the period of time that you, as the beneficiary, are in the hospital or a skilled nursing facility, plus that additional 60 days immediately following the day that you leave that skilled nursing facility. So benefit periods are important, especially within Part A, because they tell us whether or not the beneficiary will be responsible for paying the deductible and how much of that deductible, depending on how many days they ended up spending in the hospital, right? We talked about how that 61 through after that 61st day, it changes in comparison to those first 60 days, whether or not they have reserve days, all that, right? So let's take a look at a sample benefit period. I always feel like this is the easiest way to kind of grasp is to kind of use a real life example. So let's say that you spend 5 days in the hospital. You'd be responsible for the first $1,652 spent on your care during that time. Then you leave the hospital and you're sent to a skilled nursing facility for 20 days. That didn't cost you a dime though, because the first 20 days do not have any cost sharing associated with them. So then you return home safe and sound. 60 days later, so long as you don't wind up in the hospital again, you're out of your benefit period. And if you need to go back to the hospital again on that 61st day, you restart a new benefit period and you must pay that deductible again. So that $1,652 would then be paid by you again on that 61st day. But if you went on the 59th day, that you're still within your benefit period, so you wouldn't have to repay that deductible again. So making sure that you're knowing when those periods start and end are going to be crucial for you to understanding how much you would pay if you were to go to the hospital. Okay, so Part A's late enrollment penalties. So if you aren't eligible for premium-free Part A, which again, most of us are, but some of us aren't, and you don't buy it when you're first eligible, your monthly premium will go up 10%. You'll have to pay the higher premium for twice the number of years that you could have had Part A but didn't have it. But again, most of us qualify for Part A coverage with no premium in the first place. So keep that in mind for those of you who have clients who might not qualify for that free Part A, to have them sign up as soon as they're eligible, so they don't end up having to pay those fines for twice the number of years that they neglected to sign up. Should I sign up for Medicare Part A? 99% of people don't pay for Part A anyway, so probably. If your premium is required, it could delay triggering that LEP. If members are covered by a group health plan from their employer with fewer than 20 employees, Medicare secondary payer rules, there we go, determine that Medicare is primary. So they're going to want to sign up for that. If members are covered by group health plans, form an employer for more than 20 employees, Medicare Part A supplements that group plan if that is possible, but the group plan would pay first. So that's a little bit of a different story. It might not be as urgent or as important for someone with a group health plan to sign up for Part A when eligible, because we'll have that special enrollment period when they leave their group health plan. But when there's fewer than 20 employees, that's going to be when you're going to want to really make sure that that employee is grabbing that Part A for themselves. If you have an HSA, you are no longer able to contribute to that HSA once you sign up for Part A, right? So if you are someone who is really valuing that freedom to contribute to that HSA, if your client is, I should say. Make sure they're aware that that's not going to be a possibility for them once they hit up Part A and start using it, right? So that money's not gone. They still have access to that money. It's not gone. They just can no longer contribute to that HSA, right? Either make sure that you have the max that you can contribute to that HSA. I don't remember the numbers off the top of my head, but make sure that they have that max contributed, or that they're okay with the amount that they have in that HSA. Again, they can still take out of it. That money's not poof gone. It's just no longer as fluid, or as you're not as free to contribute to it as you once were. So awesome, Richard. Glad that you brought that up. So I'm going to throw the knowledge check. Oh, I just hit my laptop there. Sorry about that. So let me throw the knowledge check up here for us. So Blanche has worked as an administrative assistant for most of her career. She'll be turning 65 in 2 months and is not yet receiving Social Security. She's unsure about whether she will enroll in Medicare Part A. Which of the following reasons might help convince her to enroll? Either she will be eligible for premium-free hospital coverage, she'll be eligible for premium-free doctor visits, or she'll be eligible for premium-free vision and dental. Right. She is eligible for premium-free hospital coverage. Perfect. Yes. She does not get premium-free doctor visits through Part A, and vision and dental is not included in A or B. That's a totally different thing. That's one of those maybe value-added benefits you might get in Part C, right? So as you can see, we're back on our pyramid. We're all the way on the right-hand side this time with Part B. This is the other foundation to Medicare. Parts A and B, you might hear them be called Original Medicare, Classic Medicare, something like that, because for two reasons. One, they were the first ones to come out back in 1965, and generally you must be enrolled in both of those before you can tackle some things like Part D and Part C. So beneficiaries can purchase Part B even if they are ineligible for free Part A. Part B premiums are always charged on a monthly basis. Premiums can change every single year and have every year in my experience since I have started in the insurance world. The estimated base premium for 2024 will be $174.80 per month. Last year it did go down to, I believe it was $164, $168, something like that. Now it is estimated that it will be $174.80. Stay tuned to know the exact number at a later time. And there is a reduced premium for those of us with immunosuppressive only coverage. And that was $97.10 in 2023, but there has not been an estimate for what that will be for 2024. So probably somewhere around 100, I would guess, maybe. So that's that. So for Part B, there is something that some of us will have to be aware of when we sign up for Part B, and that is IRMA, the Income-Related Monthly Adjustment Amount. So if a member has modified adjusted gross income as reported on IRS tax return from 2 years ago above a certain amount, that beneficiary will pay the standard premium amount and an income-related monthly adjustment amount that will be added on. This is an extra charge added to the premium. This has been around since 2007. These income-related monthly premium rates affect roughly 5% of the people who are enrolled in Medicare. So a little more than those Part A people who would have to pay for Part A, but less than 5-6% or so. So if you end up having to pay a higher amount for your Part B premium and you disagree though, if your income goes down over the course of that time, you can call the Social Security offices and talk it out with them. You aren't beholden to paying that amount. You can work it out with them. So here is a chart that depicts the estimated IRMA calculations for 2024. So again, these are just what the Medicare Board of Trustees has guessed that these premiums will be. Premiums will always be determined by the income that person has 2 years previous to ensure taxes have been completed for that full calendar year. So while these premium figures are indeed for 2024, the tax filings are taken at year 2022 to determine what that person will pay for a premium. So as you can see within the chart, those of us making $97,000 or less as an individual would pay the standard Part B premium. And then within certain income brackets, the higher the income bracket is, the more that is added on to that Part B premium monthly. And then that, of course, would also change based on whether or not the taxes are being filed married, joint, or married separate. So for those of us who have some of those clients who might be affected by this, this is a great chart to head back to. So Medicare Part B covers medically necessary outpatient services and supplies, including things like doctor services, which are services that are medically necessary, outpatient medical and surgical services and supplies for approved procedures like x-rays and stitches, clinical laboratory services, such as blood tests, urinalysis, and some screenings, DMEs like walkers and wheelchairs, diabetic testing supplies, preventative services like exams, screenings, and some shots or vaccines to prevent, find, or manage a medical problem. It's like flu shots. Home health services. You can use your home health benefits under Part A and Part B. There's slightly different services and slightly different coverages between Part A and Part B for those home health services. Part B is going to pay for your home health care if the inpatient hospital stay doesn't precede the need for home health care, or when the number of Part A covered home health visits exceeds 100. There's a little more detail in that in the Medicare and home health care brochures, or you can just visit cms.gov for more information about those things. There's a slew of covered preventative care services provided by Medicare, but be aware that these are not the same as what is mandated by the ACA for non-Medicare plans. So this is not like, I always call them the 10 commandments of healthcare, essential health services. These are not the same. As you can see, there's definitely more than 10 on here. They are covered and not the same, right? So during either the welcome to Medicare visit or the annual wellness exam, the provider will perform a cognitive function screening to help catch early signs of dementia and Alzheimer's. During either the welcome Medicare visit or annual wellness exam, the provider will evaluate current prescriptions for opioids, risk factors for opioid use disorder, and evaluate and refine treatment plans to include non-opioid treatments when indicated. So those are a couple extra things that aren't necessarily in those essential health benefits that would be provided to someone upon entrance to Medicare. Right, so in addition to the premiums, there are some other costs you will pay within original Medicare. So the annual Part B deductible is estimated to be $240 in 2024. If you have original Medicare, you pay the Part B deductible, which is the amount a person must pay for healthcare each calendar year before Medicare starts to pay for anything. This amount can change every year in January and has. This means that you must pay the estimated $240 first of Medicare approved medical bills before Part B starts to pay for that care. There are co-insurance payments for Part B services. In general, it's 20% for most covered services for providers accepting assignment. For example, members pay 20% of every doctor visit after they've met their deductible. And there is no limit to this 20% and no out-of-pocket maximum. So your client could end up paying for a while at that 20% if they go to the doctor a lot. Durable medical equipment is also covered at that 20% co-insurance after the deductible. Most preventative services have no co-insurance, and Part B deductible doesn't apply as long as the provider accepts assignment. We've mentioned that a little bit before, right? So this is important as well, okay? So accepting assignment means that there's an agreement between Medicare and that healthcare provider as to how much a care or a supply might cost. And that is how much will be billed, and that is how much will be paid. If there is a provider that does not accept assignment and your client goes to that doctor or provider or what have you, and assignment is not accepted, they are responsible for that difference, unless they have a supplement plan. So keep that in mind as well, that when that client is going to find a doctor for them, make sure that they are asking if that provider accepts Medicare assignment. That's important, right? It can be up to 15% higher of a charge. There is a cap on how much more they can charge than what Medicare assigns, but they are responsible for that entire amount. All right, so that Part B late enrollment penalty, if you don't enroll in Part B, just like Part A, when you're eligible, that monthly premium will go up, but it will go up in a different way than the Part A premium will. So it will most likely go up 10% for each year you could have signed up for Part B but didn't. This penalty is recalculated every single year, and you do have to pay that penalty for life, unlike Part A, like we said earlier, which is twice the number of years that you did not have Part A and should have. So for example, if someone was first eligible for Part B in July of 21, but didn't enroll until January of 23, that person would pay a 20% late enrollment penalty. And that premium, they would take that person's premium, multiply it by that 20%, add that into the base premium, and that would be that person's premium for the rest of their life instead of that lower premium. So again, making sure that your clients sign up at the right time is really important to avoiding those penalties. Should I sign up for Medicare Part B? If you're already getting Social Security benefits, you'll automatically be enrolled in Part A and B without additional application. The Part B premium is usually deducted from monthly Social Security, railroad retirement, or federal retirement payments. The amount depends on your income and when you enroll in Part B. If you delay enrollment, you may have to pay a lifetime penalty, which is then added to your monthly Part B premium, just like we talked about earlier. People who don't get a retirement payment or whose payment isn't enough to cover the premium get a bill from Medicare for their part of the Part B premiums. The bill can be paid by credit card, check, or money order. Having employer or union coverage while you or your spouse or family member, if that family member is disabled, is still working, can affect that Part B enrollment right as well. So this includes federal and state employment, TRICARE active duty military service. You should contact your employer or union benefits administrator to find out how your insurance works with Medicare and if you should enroll in Part B during your IEP.
Hey guys, I'm going to post a link in the chat. We get a lot of questions about what Part B pays for, or another one is how Medicare is covered outside of the United States, what's covered by, if someone's diabetic. So I'm going to post a link. There's a lot of publications on Medicare.gov, and this link will take you directly to how things are covered under Medicare.
All right, awesome. That will be helpful for. So next knowledge check is, let's go back to Blanche, who is turning 65 in 2 months. Her family has a history of colorectal cancer. She's worried about how she will pay for those preventative screenings. What might you say to reassure her as her agent? So it looks like most of us got this one correct. So the correct answer is B. There is a $0 copay for most preventative services with Medicare. If you answered A, you are kind of correct. They do cover yearly physical exams, but that's not all they cover. They do cover a lot of the other preventative services, like that opioid care we talked about at the initial Welcome to Medicare, physical, other preventative services. I don't have them all memorized, I'm not going to lie, but there are other preventative services that are supported with Part B. Patients are not responsible for 50% of the cost of all services under Part B. That's just not a thing. Okay. So unless we have any other questions, let's keep on keeping on with those supplemental plans. So you'll notice that we are now at the top of our pyramid. We've talked about 2 of the 3 things in the foundation. It makes a lot of sense then now to continue to the top of the pyramid, because these Part C is kind of like AB put together with some extra bonuses involved. So let's take a look at what that looks like. So Medicare supplement insurance, or you might have also heard it called Medigap, is a health insurance policy that is sold by private insurance companies to fill in the gaps that original Medicare left for your clients. So Medigap policies can help you pay your share of coinsurance, co-payments, or deductibles of the cost of Medicare covered services. And some Medigap policies also cover certain benefits that original Medicare doesn't cover. So Medigap policies don't cover your share of costs under other types of health coverage, including standalone Medicare prescription drug plans, also known as PDPs, or employer union group health coverage, Medicaid, Department of Veteran Affairs benefits, or TRICARE. In all states except for Massachusetts, Minnesota, and Wisconsin, Medigap policies must be one of the standardized plans that are available to us. They are A, B, C, D, F, G, K, L, M, N. They can be easily compared. We'll see a chart in a second. Each plan has a set of benefits that are the same for any insurance company. So if you look at Humana in comparison to Blue, in comparison to Priority, you're not going to see a huge difference in these plans because they are regulated. You might see some additional things possibly, but they're not going to be less if you're going to a different carrier. They are pretty well standardized. Benefits are the same, but the cost is where you're going to see the differences. Each company decides which Medigap policies it will sell and the price that it will sell it at. But those prices must be reviewed and approved by the state. Other differences include pre-existing condition waiting periods, crossover of claims from Medicare administrative contractor to the Medigap policy, guaranteed issue, stuff like that. The premium is determined by attained age, community pools, or age at issue. So that might be another thing that might change the price of your Medigap policy. So premiums are charged, there we go, on a monthly basis. They vary by plan, carrier, and location. They can be community rated, issue age rated, or attained age rated. And medical underwriting can be applied sometimes, not all the time. Premiums are still charged to those who choose a Medigap plan. You will still pay a Part A premium if you need to do so. But again, most of us don't. And you pay Part B, you will pay your Part B premium as well for most of those Medigap plans. So if you get a Med Sup plan, you will have to pay 2 premiums for your healthcare, possibly 3 if you're paying that Part A premium as well. So this is the chart I mentioned earlier that can easily compare all of the Medigap plans, A through N. Again, these are not updated for estimates for 2024, so the out-of-pocket maxes are reflective of 2023, but Medicare supplement plans are regulated through CMS like we talked about. So no matter what carrier provides that plan, it's going to be the same. These plans are different. Each letter covers different things, but not all carriers will offer all of them. They can pick and choose most plans they offer. There are some regulations behind which ones they do need to offer and to whom, but they do, for the most part, get to pick and choose. For example, all carriers must offer Medigap Plan A, C, and F if they offer any. So those 3 have to be offered by the carrier if they do offer any Med Sup plans. Not all plans will be available for those who are not over 65. That's not regulated either. They just have to have at least one. So it might be a potential that one of your clients who is over 65 hits up Medicare Part F, and that's not available to the under 65 person with ESRD. They have to have Part A if they're going to stay with, say, Blue, or because that is just the only plan that is offered for that person for Blue. Maybe if they want Part F, they have to go to Humana, whatever. So in enrolling, you have guaranteed acceptance. Usually the best time to buy a Medigap policy is during your Medigap open enrollment period, or OEP. It begins when you're 65 or older and enrolled in Part B for the first time. You must also have Part A to get a Medigap policy. You have a 6-month Medigap OEP, which gives you a guaranteed right to buy a Medigap policy. Some states may have a longer period. Once this period starts, it can't be delayed or repeated. So during your Medigap OEP, companies cannot do any of these things. They cannot refuse to sell you a Medigap policy that they offer. They cannot make you wait for coverage, even if there is a waiting, or there can be a waiting period for pre-existing conditions if you don't have credible coverage before that OEP, but they cannot apply it if you did have credible coverage before this OEP. They cannot charge you more because of a past or present health problem. So if you have a client that might have some of these things, it's really important to make sure that you're getting those. You may want to apply for, or during the OEP, you may want to apply for a Medigap policy before your OEP starts if your current health insurance ends the month you become eligible for Medicare, reach 65, or have continuous coverage without any breaks. You could also buy a Medigap policy whenever a company agrees to sell you one, but there might be some restrictions on that. So Blanche has made the leap and enrolled in Medicare Parts A and B. Looking forward, she'd like to minimize her out-of-pocket costs in the event she needs to be hospitalized. Which course of action might be a good fit for her? All right, you guys were quick on the draw on that one. Yes, everyone got that one. Medicare supplement plans is a good option for her. Perfect. Let's keep on keeping on. So Part D is our next section. This is kind of the center of our pyramid, because unless you're getting these drugs within a hospital stay, most of the time they are not covered through these other areas, and then you'll need some sort of Part D. So Part D is Medicare prescription drug coverage. If you choose Original Medicare and you want prescription drug coverage, you must choose and join a Medicare prescription drug plan, or PDP. Usually these are monthly premiums. These plans are run by private companies, just like Part C and the Medigap plans. You cannot sign up for a Medicare Part D plan through CMS. You must use a carrier. Medicare contracts with private insurance companies that offer prescription drug plans to people with Medicare. Everyone with Medicare can get Medicare prescription drug coverage by enrolling in a Medicare drug plan. You might pay a penalty if you join later. You might get this coverage through your Part C or a Medicare Advantage plan. But again, to join that MA plan, you must have Part A and B. Costs are going to vary depending on the plan. Most people pay their premium monthly for their drug coverage, and you might pay a share of your prescriptions, or you might pay a deductible depending on what plan you choose. So Medicare Part D is Medicare prescription drug coverage. If you choose Original Medicare and you want prescription drug coverage, you are going to want to join that prescription drug plan. Part D plans are optional and might be subject to IRMA as well. Just like we learned about for Part B, there is IRMA for Part D as well, and this is what that will look like. So beneficiaries pay only the plan premium if their income 2 years ago was $97,000 or less for an individual, or $194,000 or less for a couple. And then just like that Part B chart, if they report a higher income adjusted 2 years previous, then they will add to the premium. We cannot figure these numbers exactly because it will depend on which policy that person has, right? Each premium is going to be different, but it will add the same amount each time. And again, these numbers are estimated for 2024. So let's say that this person has a $100 Part D premium. They would add, if they made $97,001 as an individual, they would then pay $112.90 for that Part D premium. So the cost sharing phases. First, there are 4 phases for Medicare's Part D cost sharing. The first one is the deductible phase. Some plans don't even have a deductible phase. They just go right into the initial coverage phase. Anyone in this phase will pay the full price for that medication until that deductible is reached. It is estimated that this deductible will be $545 in 2024. Then you will remain in this phase until the total cost of your drugs paid for by both you and the carrier, there we go, reach that predetermined amount. For most plans in 2024, the initial coverage period will end after drug costs accumulated $5,030 in total, estimated again. Total drug costs in this amount include the amount that you and your plan have paid for those covered drugs. So it's not just the client that has to pay that little bit over 5K there. It is the client and the plan. So you'll be in that initial coverage portion until you hit that amount. Once you pass that amount, you get into the coverage gap. And in this stage, the beneficiary is responsible for 25% of the drug costs, while the manufacturer and Medicare are responsible for the rest. The costs for you and the manufacturer are applied to the out-of-pocket max. And once that number reaches 8K, you'll head into the final stage. 8K is again estimated for 2024. And then finally, you will get into the catastrophic phase. And in that catastrophic phase, there will be no more than 5% co-insurance paid. Part D will pay the 20% of drug costs instead of the previous 15. These amounts are new for 2024, and it'll change again in 2025. So keep those in mind for those of us who might have clients that are going to reach that catastrophic coverage phase for their drugs. So there are some late enrollment penalties associated with Part D. You will get a penalty charged to you if you don't enroll when you're first eligible, or if you have a break in credible coverage that lasts more than 63 days. So the late enrollment penalty is determined every year. It is based upon 1% of the average national base Part D premium, and then compounds for every month eligible and not enrolled. And it continues for the duration of the time that you have the Part D coverage, and is just straight up added into that Part D premium. So it's everyone's premium will be different, but the late enrollment penalty is calculated the same for each person. So you should sign up for Medicare Part D if you're already getting Social Security benefits and would like some more coverage for your drugs. You should not enroll in it if you already have credible drug coverage, or it might make you ineligible for your union plan and you like that plan better. All of these statements, A, B, and C, are all true. So Blanche might have, so a deductible is applied at Part B sometimes. She might have to pay IRMA, and her co-payments and out-of-pocket costs must exceed $8,000 before she gets into any sort of catastrophic phase. So let's go really quick through some Medicare Advantage plans. So Medicare Advantage is offered by private companies and compares Part A and Part B. It becomes the primary payer and may provide additional benefits, and most plans do have Part D rolled in. So Medicare pays a fixed amount to the private carriers. Medicare Advantage plans often have different out-of-pocket costs, and they often have different rules for accessing those services. So if you are talking about why certain benefits are different for different neighbors, or that even though they might have the same Part A and Part B, that would be because they're going through kind of different Advantage plans. They might be enrolled in different Advantage plans through different carriers, and that might change. Unlike Parts A and B, just standard, that are always the same, right? So you might wonder why a beneficiary would choose a Medicare Advantage plan, and that's because it has everything original Medicare covers, including some other additional benefits. And whether or not those additional benefits are worth it to your client is up to them, but they might also end up paying something a little different in comparison, right? So Medicare Advantage offers at least the same coverage as original Medicare, but is going to offer additional things. Some Medicare Advantage plans advertise a $0 premium, but even if that's true and they are getting a Medicare Advantage plan with a $0 premium, you're still going to have to pay your Part B premium. So keep that in mind as well. Make sure that your clients understand that as well. But all three of these statements are true. Medicare Advantage plans might cover dental, vision, hearing. Medicare Advantage plans might cover prescription drugs. And Medicare Advantage plans do make care a little bit simpler for your clients by providing one card, one bill, and one explanation of benefits. that might be another benefit to the having Medicare Advantage plans. So Medicare enrollment, how can someone enroll and when can someone enroll? So I'm going to just put these on the screen really quick. These are all the different enrollment periods that one can use. We have the IEP, GEP, SEP, AEP, and MAOEP. Whew. Okay. So the first one we're going to talk about is someone's initial enrollment period. There are a couple of instances where they might get enrolled on Medicare automatically as well. So if you're collecting Social Security prior to turning 65, you will automatically get Medicare. And the package is rolled out 3 months prior to the 65th birthday. So these are all the instances where someone would automatically get enrolled in Medicare. So non-automatic enrollment would happen if the person approaches ages 65 but is not getting Social Security benefits already, or if they have ESRD. I always try my best to stay within the hour, and I know I talk too much, but I really just want to make sure everyone understands and we get all that information out there. So we made it right at 11.
Hey guys, so if you do have questions and you're not really wanting to put them in the chat, maybe it's something that you want to take offline, feel free to reach out to your account manager. I'm an account manager here at Action. We've got quite a few on the team. Reach out to us if you have questions, and we're here for you throughout all of the craziness in the next few months. So good luck to you all, and we look forward to hearing from you.
Thank you, Jessica. And once again, I just wanted, before we close out today, thank you for spending some time with me and Jessica. We really appreciate it. Reach out to her, reach out to me.